Hello and welcome to another Pipecast. Today we're going to continue medications and we're going to have a closer look at fentanyl. Now, as you will see very soon, there's been a significant amount of changes, but pretty much have only one indication, okay, and that is for the use in severe pain. It does mention that when dealing with chest pain and suspected cardiac chest pain, that fentanyl is actually preferred over morphine, because morphine may delay the absorption of clopidogrel, which is a potential antiplatelet that may be used further on in the treatment. Now, fentanyl has been out for a while. It's synthesized in China mostly, and unfortunately it's become quite a drug of addiction and quite a street drug as well, because it is significantly stronger than the rest of the opioids in the class. So when you're administering fentanyl, you need to be really careful that it is so much stronger. So during a continuum of care, especially if it goes prolonged, someone's in trauma or someone's in significant amount of pain, the patient may have a series of different opioids to help keep their pain under control. So when you are mixing opioids, you need to have a general idea of how much equivalency each one of them are. Now, the two main opioids that we use is obviously our fentanyl and morphine. Now, whilst in the acute setting it is never recommended to jump and switch between the two, but when moving into extended care, it is feasible that morphine can be replaced for fentanyl due to its prolonged half-life. So when you're giving morphine versus fentanyl, the easiest way to think about it is it's to a multiple of around 100. Meaning if you're giving 0.1 milligrams of fentanyl, it's equivalent to 10 milligrams of morphine. Now, our doses IV for fentanyl is around your 20 microgram, which is 0.02 milligrams. Okay, so what that means is when you're giving your 20 micrograms of fentanyl, you are giving 2 milligram doses of IV morphine. It just is an easy conversion. Okay, looking at fentanyl more closely, fentanyl acts on a lot of different receptors, which we'll look at when we have a look into pharmacodynamics, and as a result of that, it's absorbed rapidly through the body, which means its bioavailability is generally around 50%, okay, because 50% of it affects the other receptors that aren't associated with the target areas of pain. Okay, now when you're giving it IV, it is a rapid, almost immediate onset of absorption. When you're going IM, it's 7 to 15 minutes. Now, they did a comparison between IM, IV, intranasal, and subcut, and what they found was it has a similar onset and similar benefits of actual pain relief. So I don't have the absorption rate for subcut, couldn't find it written anywhere in a reputable site, but there are quantified studies that prove effectiveness. As it distributes through the body, it becomes pretty highly protein bound, okay, good 85%. So that is the reason why it has quite an extended half-life, even though the onset is quite quick. So its half-life is 2 to 4 hours, but its effectiveness does drop off before that time, okay? So it relies pretty heavily on a serum concentration level in order to work effectively. So generally with fentanyl is you have a quick spike in effectiveness, high plasma concentration, if you will, and then as it goes through metabolism, its plasma concentration drops, so too does the effectiveness and the risks associated with the adverse effects. Now, metabolism, it's pretty much solely metabolized in the liver, and it's metabolized by an isoenzyme that fits into the class of your cytochrome. Now, it is a specific cytochrome enzyme, and the reason I've written it out in full is because it plays a role when we start dealing with interactions. Okay, looking closely at the pharmacodynamics of fentanyl works pretty much the same way as every other opioid. Okay, so opioids work by acting on opioid-based receptors. Okay, now opioid receptors, just out of interest rate, the reason we have opioid receptors in our body is because they're usually triggered by endorphins released by the brain, okay, to give us feelings of euphoria. But when they're stimulated by external substances like opioids, even synthetic opioids as well, then we get other effects. Okay, so there's 4 main classes of opioid receptors. There's your mu, your delta, kappa, and ORL, okay, which is your opioid receptor like 1. And as you can see, they all correlate with different clinical effects. Now, most opioids are mu agonists, and they have varying activities on the kappa receptor. Okay, so very few opioids that are given will activate strongly on the delta or the ORL. Now, if you look at the clinical effects of the mu and the kappa, you can see that they have your analgesia, but then they also have respiratory depression, physical depression, sedation, and dysphoria as well mixed in with them. Now, that's generally linked to our side effects. Okay, it also has a close link with the limbic system, which is where our physical dependency comes on. Now, the way it works the way as most other lock and key mechanisms. The actual opioid will come along, it will bind with these receptors. Now, an opioid receptor is made up of a series of transmembranes. Okay, so there's around 7 transmembranes. And what they are is they're coupled with inhibitory G proteins. Now, if you want to look more into G proteins, knock yourself out, you'll spend the rest of your life trying to learn around them. Now, the important thing is when this membrane is activated, it pretty much fits into a cycle linked to adenosine monophosphate. And that causes a decrease in the calcium influx by inhibiting the voltage gated calcium channel. Okay, now when that inhibitory response occurs, it actually results in the activation of a potassium channel, which leads to massive hyperpolarization. Now, it's this hyperpolarization that inhibits the neural signaling. Okay, so by stopping the calcium causes an influx of potassium, okay, out of the cell, which causes hyperpolarization, which removes the action potential. Therefore, the signal, the action potential, isn't passed on across the actual synaptic gap. Okay, so there is no pain transmission from there, and that's the way that it works. Now, it does the same thing with the secondary effects of those opioid receptors, which is why when you have too much and it blocks more of these receptors, more of these signals, we start moving into our respiratory depression and link heavily with our sedation. So because of that, there's a significant amount of warnings and adverse effects. Okay, so it's no secret that opioids can cause life-threatening respiratory depression. There's other things to look out for. So before giving opioids, and especially fentanyl, we need to make sure they don't fit into any of the contraindications. So hypersensitivity is obviously one. Now, people with severe respiratory-based disorders like bronchial asthma or other obstructive airway diseases, it is contraindicated to give fentanyl to. Just because they're already at a lower base rate, that in the event respiratory depression comes in, they will crash a lot faster. Now, there's a strong link with mu receptors and also with the gastrointestinal system. So if anyone has biliary colic or GIT obstruction, you also do not give fentanyl to, because the mu receptors are also responsible for slowing down gastric motility. If you slow down gastric motility on a GI obstruction, then it's going to result in needing surgery. Other contraindications include people on MAOIs and people with head injury or raised intracranial pressure. Now, the adverse effects are as you would expect. The most common one is you get a rash and quite itchy, but other side effects can be bradycardia, drowsiness, and sedation. You can also get low blood pressure, especially orthostatic blood pressure. Now, low blood pressure associated with fentanyl is a little bit different than morphine. Fentanyl is known to turn off a catecholamine response as opposed to causing the pure vasodilation. So, as a result of lack of catecholamines, you can get the lack of vasoconstriction, which gives you a lower blood pressure. Okay, and other ones very common with all opioids is incidence of nausea and vomiting. As far as interactions go, we'll talk a little bit about your MAOIs. So MAOIs are a slightly older class of antidepressant. Now, they're not prescribed anywhere near as much as they used to be, okay, but there are still people that are still on it. So if in the event you meet someone and they're on an antidepressant and you don't quite know what it is, it's always recommended to look it up, see if it does fit into the MAOI category, and if it does, fentanyl is definitely not to be given. Now, if you do give it, it actually increases the toxicity of fentanyl. Okay, so the reason it's contraindicated is because the toxicity associated with fentanyl will be increased on anybody who is taking MAOIs. Other things you need to be careful with is mixing with other opioids, as we've already spoken about, and also mixing with benzodiazepines. It has an increased risk of causing respiratory depression, despite the old advantage people used to take in causing that dissociative effect. Other serious interactions come into your classes of your CYP3A4 inhibitors. Okay, so the same isoenzyme that we spoke about before. If you're taking a drug that is the inhibitory of that, then you run the risk of increasing the plasma concentration of fentanyl, and in turn increasing the sedative effect and the other associated respiratory depression. Now, some common ones that are used include your macrolides, okay, macrolides antibiotics like azithromycin, and also your antifungal ketoconazole. Okay, looking closely at the sedation score. Now, the sedation score that's written in the PCCM is not a true sedation score. Okay, so your true sedation score was written a fair while ago, and if you haven't heard it before, it's Pazero's opioid-induced sedation score, or the POS. And what it's designed for, it's designed for prolonged care. It's designed for hospitals where people are on regular doses of opioids. Okay, it's not really used in the acute setting, even though intuitively it is. It's just a way of making sure that you're not giving fentanyl to people that really are showing that signs of drowsiness, and therefore the effects of the opioids activating too many of these opioid receptors. So the bottom line is, anyone who's awake, alert, and in severe pain can be given more fentanyl. If they are slightly drowsy, they're asleep, but they're easy to wake up, and they can stay awake for greater than 10 seconds, then you can give them more of a dose if they are in pain. But realistically, if somebody is asleep and falling asleep, just after 10 seconds, from an acute setting, that's quite comfortable. Okay, when you start moving into prolonged care and they're waking up in pain, but then falling back to sleep, then you can start looking at giving more of a dose. Okay, maybe a smaller dose, but you can give more. Anyone over that, so a sedation score of 2 to 3, you no longer are looking at giving them any further opioids. Okay, what you're looking at is monitoring the adverse effects of those opioids. So you're looking at, is the sedation linked with the respiratory status? Is it causing hypoxia? Is it causing hypertension? Do I need to do anything else? Okay, once you get to the 3 level, that's when you start thinking about giving naloxone, bringing them back a little bit. Okay, now if they're just into the sedation score of 3, you give them a little bit of naloxone to bring them back. You don't want to take away all the effects of the opioids, okay, obviously, because then you bring back the pain as well. So it's just a tool that's been brought in. Like I said, in the acute setting, we've pretty much been doing it just instinctively. We're not going to give more doses of opioids to a trauma patient who is sleeping in your ambulance while you are on transport. Okay, that's always happened. So this is just taking it that next step, holding on to someone for an extended period of time. We have an option of what to look for, and we have something to hang our hat on to say that this is the stage that they're at. We feel like giving more because they're still in pain. Now we have something that says that we can. That's all it's for. Okay, another thing that's been brought into our world, okay, fentanyl's quite a long one because there's been so many changes and so many things brought in, is your fentanyl lozenges. Okay, now you will not find fentanyl lozenges in the PCCM, however they have been approved for our use. Okay, now we are allowed to use the 800 microgram only version. Okay, now they've been around for a fair while. They've been used for cancer patients a lot. So cancer patients would actually take these home and just use them with the protocol. Usually one, if it's not quite enough, you take two, but they're no more than two, then you'll call an ambulance, that sort of thing, to get your pain under control. Now, they're available in a whole range of strengths, 2, 4, 8, 1,600 micrograms. We're stuck with the 800 microgram one, which has been trialled, okay? TCCC has been trialled in the battlefield with trauma patients, and it's been proven to be quite effective, okay? As effective as other opioids, okay? So they did a comparison with a bunch of other opioids that are used for pain relief, and fentanyl lozenges performed very, very well with them. Now, as far as pharmacokinetics, we do sit as well around the 50%. And a lot of people are really nervous because we're giving 800 microgram dose, okay? But the thing you have to think about is most of that, it's not like giving 800 micrograms into a muscle or subcut, and it's definitely not like putting 800 micrograms into a vein, okay? So it's absorbed two different ways, okay? So you do get the rapid absorption in the mucosa, but then you also get a very long and a slow, prolonged absorption from the GIT. Okay, so generally speaking, when you're looking at the pharmacokinetics, the absorption of fentanyl is from those two methods. Now, about 25% of the dose is absorbed through the mucosa as the person sucks on the lozenge. Okay, so not straight away, not really a stat dose, a long, slow 25%. Okay, the rest of the 75% is swallowed, so therefore goes through the GI tract. Now, only 1/3 of that 75%, so around 25% of the total dose, actually escapes your first pass metabolism and first pass elimination. Okay, so that means that generally we get around the 50% bioavailability, same as we did with the other routes of doses, but it's at 50% bioavailability over an extended period of time. Now, when you look at the plasma concentrations of these lozenges, they have a mean peak plasma concentration of around 20 to 40 minutes, which means you can expect to get the highest effects, both positive in pain relief and adverse effects, around the 20 to 40 minute mark. So giving fentanyl lozenges to patients, we want to monitor them really closely at the 20 to 40 minute mark. They get past that, generally they're on the way down with the plasma concentrations, and we can start looking at further care. You don't want to be giving fentanyl lozenges and then it didn't work fast enough, pushing fentanyl into the muscle and then waiting for the lozenges to kick in, because it will have an accumulative effect that can easily result in an opioid overdose. Now, there are a lot of people that are worried about fentanyl lozenges, and one of the big warnings that it puts out there is the associated risk with using it on people that are in circulatory shock. So if someone has lost a significant amount of blood and they're showing signs, early signs of circulatory shock, okay, just be really careful with the use of your fentanyl lozenges. Okay, finish up with a little bit of clinical take-home. We've talked a lot about clinical take-homes throughout, so we're just going to talk a little bit about how to mix the doses up. When you're looking at your IV dose, it's always best to titrate that with 3 or 8 mils of normal saline. Okay, so this will make a solution of 20 micrograms per mil or 10 micrograms per mil. Now, it doesn't really matter which one you use, you're still giving the same dose. The advantage of using 8 mils is you can easily give 10 to 20 mils. Okay, but if you want push for space, you want to use a smaller syringe, 5 ml syringe, then you can go to 20 micrograms per mil. Bottom line is, depending on the activity you're doing and how you have to operate, make the call before you go out. Know what you're going to do, know how you're going to mix it, and know what your concentration is going to be. So then when you put under the pump and you're tired, sleep deprived, you know what the mass is and you know how to administer these drugs safely. And when we're giving it the subcut route, it's best to use a 2 ml syringe for our demographic. So we're dealing with a young, healthy demographic. 2 ml syringe, draw up the whole 2 ml, then you can either give the full 2 ml, which is your 100 micrograms, or 1.5 mils, which is your 75 micrograms, and that's pretty much what you'll use for our demographic. Now, if you want to lower the dose because you're dealing with a different demographic and you want to give between your 30 and your 50 or less, then it's best to use a 1 mil syringe and only draw up what you need, okay? Because they're the patients that you're worried about the effects on their liver, you're worried about the effectiveness of their kidneys. So if you want to give 30 or 30 micrograms has been ordered, it's been ordered for a reason. So only draw up what you need in the 1 mil syringe and then administer it and then swap the needle. Now, intranasal is available only on MO's order. Now, whilst technically you can just get a syringe and squirt it up someone's nose whilst they breathe in deeply, it is way more effective if you use an atomizing device itself. Okay, and it sits on the top of the syringe and it turns it into a mist. Okay, highly effective, rapidly absorbed. Okay, so that's an option that is available on MO's order. Okay, so that finishes the lesson on fentanyl. Was a bit of a long one, but like I said, there was a lot of new things that were brought in. We've got new doses, lozenges, sedation score, so plenty of things to talk about. I hope you got something out of it, at least a spark in interest to look into things further if you need to. But until next time, take care.